Hello and welcome back to the Case of the Month. My name is Amr DeBase. I'm the current hand and upper extremity fellow at Virginia Tech Perilunate. For this month, we're going to go over arthroscopic management of lunate dislocation. My attending for this month is Dr. Cesar Bravo, our program director. We have no disclosures. MF is a 58-year-old right-hand dominant male who fell about 9 feet and was seen at the ED for evaluation of wrist pain thereafter. He reportedly was building a roof for a shed when he fell from that height directly onto his outstretched hand. He came in reporting of some pain and soreness to the wrist and a little bit of numbness over the median nerve distribution, but nothing alarming. On exam, his skin was intact, he had no open wounds, he had some abrasions over the volar wrist, he was tender to palpation over the volar wrist, he was neurovascularly intact distally, and he had some significant pain and was unable to move to make a full composite fist. Of note, this patient is a professional golfer, and his injury was preventing him from going back to golf, and this is a very high priority for him. Here are his x-rays in the emergency department. These are 3 views of his left hand demonstrating a Mayfield 4 lunate dislocation. So you can see here, most notably in the AP and lateral views, the loss of the disruption of Galula's lines, and you can see the lunate flexed and dislocated out of the radiocarpal joint and really into the carpal tunnel here. A closed reduction was performed with conscious sedation in the emergency department. This was successful. The radiocarpal articulation was restored at the lunate facet, and the patient did not have any median nerve symptoms. A post-reduction CT scan was obtained to look for any occult fractures or any other injuries, and you can see here in the coronals there are no injuries to speak of. Here the sagittals along the scaphoid axis didn't demonstrate any occult fractures to the scaphoid or anything else. And then you can see here over on the right 3D recon showing the successful lunate reduction there. So this is a middle-aged gentleman who is a professional golfer with this potentially devastating injury to both his daily life and his professional life. The management for this patient is to return him to activities of daily living and to his sport as soon as possible. And so the plan was for definitive management was to try to be as minimally invasive as possible and treat this gentleman with an arthroscopic technique. We first placed the patient in a traction tower in the operating room. We performed arthroscopy of the wrist through a 3-4 portal and a 6R portal in the standard fashion. We debrided the radiocarpal joint, including some frayed edges of the TFCC. A significant amount of chondral debris was noted at that time. The membranous portion of the SL was disrupted and falling into the joint, and this was debrided. Unsurprisingly, the volar extrinsic ligaments were intact. There was a dorsal capsular tear into the SL junction, and this was also debrided. A partial synovectomy was also carried out in the radiocarpal joint. Once this was done, we then proceeded to the midcarpal joint, which are these photos here. The captate was intact with minimal cartilage injury. Some chondral debris was noted, and this was thoroughly debrided. At this point, we did notice a positive drive-through sign at the SL interval through the midcarpal joint, but not completely all the way in the LT interval or the lunotriquetral interval. Both the scaphoid and the lunate and the triquetrum were all reducible through the midcarpal joint with a probe. So you could see here, here's our probe. Over here on the top left, you can see that interval between the scaphoid and the lunate, and then here on the right, us able to perform a drive-through sign, or at least the beginning of one, and then here the probe able to reduce the carpal bones there, and in the bottom right here, this was after our definitive management. Once we had completed the midcarpal debridement, we proceeded to move forward with the arthroscopic reduction, first by placing a radiolunate pin. This was done within a size 062 C wire. Once the radiolunate pin was established and we corrected the DZ deformity from the lunate extension, we then placed an scapholunate pin and then a triquetral pin. These are all 6'2" wires. In total, we did 4 pins, so 2 SL pins and 2 LT pins, and this was all done in combination of with arthroscopy and fluoroscopy. So arthroscopically, we confirmed that the bones were reduced anatomically, and then fluoroscopically, we made sure that the pins were in the correct position. And arthroscopy also aided in this, making sure that the wires were not placed in an errant position. This was a fairly stable and rigid construct. We then removed everything out of the joint from an arthroscopic perspective and placed the patient in a volar resting splint. These are the patient's x-rays approximately 2 months post-operative. You can see here in this central x-ray that he retained some SL widening after his injury, but you can see here on the lateral that he is not in DZ. His lunate and his SL angle is appropriate, and his scaphoid is not dorsally subluxated, and his lunate is not unstable. At 3 months post-op, this is the patient's range of motion. Again, the operative side is the left side. You can see that his range of motion is fantastic, and I think this is the advantage of the arthroscopic management for this injury. With open management, you can really inhibit range of motion of the wrist with all the scarring that takes place after the open approach. But with arthroscopy, you can really minimize this, and I think this gentleman really benefited from that. Thank you very much for watching.